All right, go ahead.
You can see my screen, just my slide.
Yes.
Yes.
All right. Okay, good. Okay, guys. So we're going to talk about GI emergencies. We're going to do part one. We're going to take a break and do part two. This is, I think, my fourth year giving the lecture. I try to change it up just a little bit, but I think most of the content you're going to get tested on is about the same. We are going to start. So we're going to talk about kind of all the way down the whole tube. So from the esophagus down to your butt in the next 2 hours. And this first part is going to really talk about kind of foreign bodies, perforation, GI bleeding, and biliary pathology. So let's start and talk about foreign bodies in the gut, right? So your signs and symptoms of an upper GI foreign body is someone that's kind of retching, vomiting, they can't swallow, they have a foreign body sensation in their throat. In children, it's most common that it's going to be something like a coin or a battery or a toy, but for adults, it's going to be small bones or it's going to be a food bolus. In 35% of the pediatric cases, they're going to be lodged in the esophagus and they're not going to be symptomatic at the time of presentation. And so, sometimes you don't actually need to do anything, especially if they're able to kind of pass some food and able to eat and drink. A lot of times this just kind of passes on its own, and there's no evidence in 5-day mortality rates between children who had imaging in the ED and no imaging. The exception is button batteries. So whenever you got a button battery ingestion, it's an emergency if it's lodged in the esophagus because it can cause erosion. If it's in the and a perforation, if it's in the stomach already, 90% of the time it will pass through the GI tract without any problem. And that's a big deal for kids. For adults, the foreign bodies in the gut you got to think about are body packers and body stuffers. So body packers are people that have kind of planned, right? They packed for this trip. And so it's very coordinated and ingestion is for the purpose of smuggling. So a lot of times they're not going to get as many problems as the body stuffers that are, the cops are on their way. They need to stuff real quick. So what they'll do is, for example, cocaine or methamphetamine users will often eat or put a bunch of bags and try to swallow them. And then what happens is the bags rupture because they erode in your GI tract and you get some pathomimetic toxicity. So you're going to get hypertension, you might get hyperthermia, you're going to get dilated pupils, agitation, tremors, seizures. And so if you come in, if you have a patient that comes in and they have a weird sympathomimetic toxidrome, something like a body stuffer is definitely on the differential. And so you have to consider. So plain abdominal radiography is usually unhelpful, but you're probably going to get it because you're going to need to know what's going on with your patients. And so just remember that, you're going to need to treat the sympathomimetic response in these folks. So foreign bodies in the gut, right? So you really need to, on the test, you're going to need to understand if you need to get ENT or GI involved. And the really differential is, are you above or below the larynx, right? So at adults, the most common site of obstruction foreign body getting lodged is in the lower esophageal sphincter. And in the child, it's in the upper esophageal sphincter and the C6 vertebrae or the cricopharyngeus, right? So, up here, this is where the kids get stuck. Down here, this is where the adults get stuck. The way
Calipari. Are you craving something sweet? Try the first one on us and let us know what you
Cam, who are you talking to, dude?
Sorry, I muted him. It's okay.
Yeah, you're going to always get a picture like this on your test. They're going to ask you where the foreign body is lodged. Is it in the trachea or is it in the esophagus? And the way to remember this is with the safe mnemonic. So sideways is airway and the frontal view is the esophagus. So this is the esophagus. I think about the vocal cords as like a slot machine. So you're kind of putting a quarter into the slot machine and it's going to be sideways. So when you have an AP view like this, the coin is flat, frontal, it's in the esophagus. If it's sideways on its side, think about it as like a slot machine going into between the vocal cords. And it's probably in the airway if it looks like this on this view. And then, when you have a question about foreign body, the decision is really when do you CT? And you really CT when something is sharp. like a fish bone, or when you're worried about a radiolucent ingestion, or there's a concern for perforation. And then the other thing that's always on the test is, this object is like 6x3, is it going to pass the pylorus? And essentially, anything that's 5x2 or larger is not going to pass the pylorus. Okay, guys, so where is this, esophagus or trachea?
Trachea.
Good. Yep. So you can see it's kind of sideways, slot machine. What about this one?
Esophagus.
Perfect. Okay, good job, guys. All right, next case, 52-year-old male presents with inability to swallow. He appears uncomfortable, sitting upright, constantly spitting in a bag. His lungs and heart are normal. You do not see anything in his mouth. Sorry. I was going to ask you what do you think he got, but he's got an esophageal foreign body. So a couple key questions about esophageal foreign bodies, right? Sometimes this is tested. Why do foreign bodies lodged in the esophagus need to be removed? Because there's a high risk of perforation. Why do objects with pointed edges need to be removed before they pass the stomach? Because otherwise you're going to get a perforation, need laparotomy. Glucagon is an option, but there's mixed data on whether or not it works. So certainly you can try 1 to 2 milligram IV when there's an obstruction at the lower esophageal sphincter. It helps decrease the esophageal sphincter tone, but the data is very mixed. And so like in a couple studies they've done, when they did glucagon versus placebo, the difference was very minimal between the two groups, but the glucagon group had a lot of emesis. And so if you're gonna use glucagon, you're gonna give it with Zofran. That's what I typically do. Nifedipine and gas-forming agents are not very useful. So they shouldn't really ask you about this on the test. They really stopped asking about meat tenderizer, but you never want to give that as well. Just remember that about 35% of sharp foreign bodies in the esophagus or the stomach or the duodenum cause a perforation. So this is fairly serious. Remember that if there's a button battery or a battery of any type, you really need to get the endoscopy, emergently. And remember that you need to remove magnets ASAP as well. If a child swallows a coin and they're asymptomatic, you can wait for 12 to 24 hours and then consider endoscopy if they haven't passed it yet. And again, remember the 5x2 rule. Anything above that, even if it's a blunt foreign body, it should really get removed with endoscopy because it's not going to pass. Okay, questions? All right, this is a 35-year-old. He drank a glass of Drano. He's complaining of nausea and chest pain, and after several bouts of retching. What are you worried about and why, and what are you going to do? So you're worried about a caustic ingestion, right? So there's a couple different caustic ingestions. You have your alkali ingestion, which is things like ammonia, lye, and sodium hydroxide, right? And that causes liquefaction necrosis. Its deeper penetration classically affects the esophagus more than the stomach. Then you have your acidic ingestions, and those lead to coagulation necrosis. So you get an eschar, and you have more shallow penetration, but it affects the stomach more than the esophagus. So I don't remember ever being asked about this, but this is kind of classic what you learn about in med school. Just remember alkali causes liquefaction necrosis, acid causes coagulation necrosis, and that's more shallow penetration. All patients with second or third degree esophageal burns have symptoms, and they're all airway complications until proven otherwise. So they're all going to have potential for airway compromise, soft tissue swelling, and you really need to intubate these patients early in the process to prevent airway compromise where you're stuck doing like a crike or something like that. So patients are going to have signs of oral burns. They may have vomiting, dysphagia, odonophagia, and some drooling and abdominal pain. These patients may do okay initially, but then they get late complications like perforations and strictures. So they're not out of the woods even after the first period. If they do okay or you maintain airway, their expected course is going to be quite complicated. So if you have someone with a caustic ingestion, just remember your ABCs, IPO2 monitor, You can use diluents for solid alkaline materials like cold milk. It usually works only in the first few minutes, but it's still worth giving. Antibiotics, if you suspect perforation, you can consider steroids, although they're a little bit, it's not really clear if they work or not. And then don't do lavage because you don't want to cause more damage when you either have them poop it out or you're making them vomit. It increases the risk of perforation and it may cause some trouble when they do endoscopy later on. So you don't need to do lavage, okay? This is a 62-year-old woman, status post endoscopy with dilation of strictures 7 days ago. And now she's here with sudden chest pain after nausea vomiting earlier today. And this is her x-ray. Does anybody want to take a guess?
Esophageal rupture.
Correct. Yep. So that's an esophageal rupture. Number one cause of esophageal perforation or rupture is actually iatrogenic causes. And it's not typical to be like 7 days out. It's a little bit of a weird vignette. Certainly it can happen, but classically we hear about it like, you got an endoscopy in the morning and now you're in the ER in the evening with these symptoms, right? That's kind of what we classically see in the ER. But on x-ray, they're going to have mediastinal air, left pleural effusion. They may have a widened mediastinum. Sometimes they may have a pneumothorax. But you can kind of see the mediastinal air a little bit here. And then they got the effusion on the left side here. And the mediastinum certainly looks wide and hazy here. So perforation can come from many different reasons. The most common are really Mallory-Weiss and Boerhaave. So Mallory-Weiss is like a partial thickness perforation. The classic story is someone went out, they drank too much, they started vomiting, and then there was blood streaking in their vomit. And typically it's self-limiting and it's going to heal on its own, right? And so we often see those patients in the ER, we do an exam, they seem okay, we observe them, we discharge them. Boerhaave is much more significant. So this is a full thickness tear. Most patients are going to have a history of some sort of emesis, but it can also be weightlifting or childbirth. And a lot of these patients are going to be elderly. Again, you can also have like iatrogenic causes. So number one real cause is endoscopy or dilatation. And then usually the patients have some underlying diseases like GERD or stricture, or they have alcohol history. The signs and symptoms, the classic one is pleuritic chest pain, worse with neck flexion and swallowing. You might feel subcutaneous emphysema, and they may have some chest pain. Just, you're going to resuscitate these people. You're going to definitely give them antibiotics. You're going to probably get chest x-ray. Sometimes now cardiothoracic will ask you for a CAT scan, and then you're going to get a surgical consult. That's really the treatment. Let's talk about esophagitis, okay? So esophagitis is the lower esophageal sphincter is dysfunctional, and essentially acid creeps back up and irritates the esophagus. So the typical history is that someone has non-exertional kind of chest discomfort, it's lower chest, and it's, it lasts for a long time and it awakens them from sleep. It's related to meals sometimes, worse when they lie down, and it's better with standing. And usually, it could be brought on by just the lower esophageal sphincter, but also some viral and yeast infections can cause it. So CMV, varicella, candida, and then corrosive agents can certainly cause it as well, like we talked about earlier with caustic injury. And then you can get like post radiation irritative esophagitis or pill-induced esophagitis, especially with tetracyclines and bisphosphonates. They're rarely, and you probably won't get tested on like Behçet's disease or Crohn's causing this, but you're going to get an endoscopy on these patients or a barium swallow, and you're going to be able to diagnose really with direct visualization. The treatment, the goal is to really reduce the acidity and improve the lower esophageal sphincter gradient. And so you're going to ask patients to either elevate the head of the bed. Smoking is a big irritant. You can ask them to stop eating chocolate and alcohol. You're gonna have them elevate the head of the bed and lose some weight. And it's classic like H2 blockers, PPIs, antacids, sucralfate. Just remember PPIs may take a week to work, so H2 blockers work a lot faster for these patients. Okay, next question. 49-year-old man with extensive psychiatric history presents 30 minutes after swallowing 30 wooden toothpicks in his group home. He's asymptomatic. What's the next step? What's the appropriate management? There's only two of you guys, so
Endoscopy with removal.
yeah, sharp object, get endoscopy. 37-year-old woman with here with complaining from large piece of steak stuck in her esophagus. She's able to swallow her own secretions, has not attempted to drink or eat. She has had impactions before and episodic symptoms of heartburn despite regular use of a PPI. After a few minutes, her symptoms resolve and she can drink water again. Which of the following was the most appropriate disposition?
Discharge with follow-up.
Perfect. Yeah, so you're gonna discharge her home because she's tolerating PO, she's able to swallow, and she's no longer vomiting. She's asymptomatic, so she can get an outpatient endoscopy if she needs to further characterize her GERD. Which of the following characteristics is an esophageal of an esophageal foreign body warrants urgent endoscopy?
I feel like uh if it was multiple, then like if it was multiple like magnets I'm thinking of, but like that's in kids. So maybe the
Yeah,
metal.
yeah, no, so it's multiple objects
Automotive
ingested
still?
together.
Okay.
Yeah, that would go. Metal, certainly you may need to take it out, but as long as it's not magnet, you don't need to take it out right away. So sometimes you can see if it'll just pass on its own as well. So really the sharp objects, button batteries, magnets, and multiple objects need to be removed fairly quickly. Okay, guys, GI bleeding. So, there's a division between upper GI bleed and lower GI bleed. So the upper GI bleed is going to have more hematemesis, so the coffee ground emesis, and it's going to usually present with more abdominal pain. Lower GI bleed is going to be more maroon or bloody stool and less abdominal pain. So when you see someone with really kind of like that sticky melena, you're going to think about upper GI bleed. And when you see bright blood per rectum, you're going to think lower GI bleed, unless it's like a very, very brisk upper GI bleed. Nobody asks you to do NG tube lavage, so disregard this. But causes of upper GI bleed are things like gastritis or ulcers, which are the most common. And then on the lower GI bleed side, it's really going to be diverticulosis. You're obviously going to have other things like neoplasm or IBD or AVMs, but diverticulosis is by far kind of the most common as a lower GI bleed. So the treatment for this, if it's an upper GI bleed that's a peptic ulcer, you're going to give a PPI bolus, and you're going to get them to endoscopy eventually as long as they're stable. If it's a variceal bleed, right? So if you're worried about kind of, a patient with liver disease history and maybe they've had endoscopy that's shown variceals before, you can do a few more things, right? You can do a PPI bolus, you can do octreotide, and you're going to do ceftriaxone. And then you're going to try to get that patient to endoscopy for banding as well. And when it's a lower GI bleed, you're going to think more about like supportive care. You're going to transfuse them. And unless they're massively bleeding out, you're going to try to stabilize them so you can get a colonoscopy. But while in the ER, you're going to get a CTA, and you're going to protocol it to see if you can see any extravasation, to see if there's anywhere IR can go. Because what you want to avoid is having to go to the OR for like an emergency colectomy. It doesn't really happen anymore, especially as IRs become more sophisticated and our CTA capability has been able to improve. A lot of times we're able to have either more localized intervention, or the bleed will just improve on its own without having to do emergency surgery. But remember, these patients are going to be really sick, especially your variceal bleeds and sometimes your lower GI bleeds. So ABCs, remember reverse coagulopathy with vitamin K and FFP. And just remember, if they're in shock or they have advanced liver disease or there's a crit of less than 30, there's a much higher mortality rate. So peptic ulcer disease. Most common cause of peptic ulcer disease is H. pylori. A lot of patients have H. pylori. NSAIDs are then the second most common. But it can also be like burns, surgery, trauma. They can have like hypersecretion syndromes like Zollinger-Ellison. And you can get HSV or CMV, autoimmune gastritis. Other risk factors is like if you drink too much, if you smoke too much, if you've been on chronic steroids. Usually if someone's on steroids chronically, they're going to be put on a PPI. Just remember that. Duodenal ulcers versus gastric ulcers. Sometimes they'll ask you where the ulcer is, and you can really determine based on when their pain is around meals. So for duodenal ulcers, the pain is going to be between or just before a meal or at night, and the upper GI tract is empty, and so there's no buffer for the acid, right? And gastric ulcers are usually going to be immediately after eating because you're going to contract and you're going to release a lot of acid, and it's going to really irritate that area. So H. pylori is the most common cause of both, but it's even more prevalent when you have a duodenal ulcer. Yeah, so you're just going to get a pain relief in the EDU with a GI cocktail. Just remember that just because someone had pain relief with a GI cocktail doesn't mean that it's slam dunk GI pathology. Sometimes, right, epigastric pain can be an indication, especially in women or older folks, as an atypical presentation of something more concerning, such as like an MI. So you have to just understand the story and the history before you kind of settle on, yeah, this guy or this patient has peptic ulcer disease or gastritis, and kind of write them off. So just remember, consider getting EKGs on these patients. Don't totally beeline straight for the gastritis GERD diagnosis. For H. pylori, which is the most common cause of these duodenal ulcers, you're really gonna be needing to be treated by triple therapy. So it's clarithromycin and amoxicillin with a PPI, or if you have a penicillin allergy, you're going to do clarithromycin and flagyl plus a PPI. The best tests are the urea breath test, and then you can also do some serologic testing. And you can also obviously do a tissue biopsy with culture staining for H. pylori, which is the gold standard when it's done after endoscopy. Okay, guys. Hepatitis is next. So hepatitis A is most common, then B, then other hepatitis. But you can get hepatitis from like amoebic abscesses or pyogenic abscesses, especially in patients that are immunocompromised. Like after dental cleanings is very classic, right? Or folks with endocarditis could end up with liver abscesses as well. So there's multiple phases of infection, but almost all the hepatitis follow this kind of pattern where phase 1, you're going to have asymptomatic patient with viral replication, and they're going to probably have positive LFTs. Phase 2, 1 to 2 weeks later, they're going to have these non-specific symptoms. They may feel fatigue, they may feel itching, malaise, vomiting, and then they're going to have this icteric phase, which is often when they present, because they're going to be like, I'm kind of yellow, my urine is dark and clay colored. They're going to have clinical kind of jaundice. They may have this right upper quadrant pain. And then the recovery phase is when everything normalizes, the icterus resolves and the enzymes normalize. And 3 to 4 months later, you usually have complete recovery, or you go into kind of latent phase of the disease. So, again, this is kind of the same thing pictured. You're going to have an infection. Initially, you're going to have viremia. You're going to have positive ALT, ALTs. And then as you develop the antibodies, and especially the IgG, and you go further out, your clinical illness has resolved, and your IgM kind of has decreased, your ALTs has normalized, and then all you really have is just IgG has persisted as a sign that you were exposed to the disease, and there's antibody formation. Questions? Okay. I think we're all familiar with this, but Hep A, you're going to get like a low-grade fever. You might get some icterus. It's an RNA virus, so it's fecal oral transmission. Hep B is a DNA virus, and so you get vertical transmission or blood or sex. Remember, this one has a vaccine that we all take, especially in healthcare. And Hep C is an RNA virus, and the most common transmission is through blood. And this one is related to a fairly significant amount of hepatocellular carcinoma. So again, 70% of patients with Hep C will chronically carry it even after clearing the disease, and 20% of the carriers will develop cirrhosis, and of those, 1 to 4% will get Hep C, hepatocellular carcinoma. So it's probably one of the number one cause of hepatocellular carcinoma in the world. There's supportive care for Hep A. Hep B is supportive care, and there's interferon and post-exposure prophylaxis. Certainly, you can give to folks that are not immunized. And for Hep C, there's Harvoni and a few other kind of similar treatments that are out there that can actually make a significant difference in the patient outcomes and can prevent Hep C, hepatocellular carcinoma and cirrhosis from developing. There's always a question on hepatitis B serology. This is one of these things that for some reason, it's very hard to remember. So I recommend you just look over this before the test, specifically looking at this graph. This is, a very common question that's asked, but really just the fundamentals of this, right, is the surface antigen is the first sign of clinical disease, and it implies that you have active hepatitis. Then you have a surface antibody, and it appears after the antigen is cleared and indicates immunity. So that could be either post-vaccine or post-infection. And then you have a core antibody, IgM or IgG, and IgM titers indicate acute infection, okay? And then you have the Hep B E antigen, which is indicative of the high infectivity, and it disappears in those who recover from Hep B, but it persists in carriers. So again, this is a fairly common picture that you're going to see in your test. Just remember that there's this window period, right? Which is like kind of right here, where there's no more surface antigen, but the surface antibody hasn't been created yet. So really the only way to check if someone has an active infection is to see if they have this core antibody up here, this kind of green solid line. Okay. We'll do some questions to kind of work on that. They may ask you about what to do if someone's exposed. I would just say if it's an exposure in a healthcare worker, if they're vaccinated, you don't need to do anything. If they're not vaccinated, then you need to give the hepatitis immunoglobulin plus the vaccine. It's a little bit different when you're a non-occupational exposure. They say if you don't know the status of the patient, the unvaccinated person just needs the vaccine series, so it doesn't need the immunoglobulin. So it's a little bit different if you're occupation versus healthcare employee versus non-healthcare employee. There's also hepatitis D and hepatitis E. So hepatitis D is often found with co-infection with hepatitis B, and it's similar transmission paths. There's no really vaccine or immunoglobulin that's affected, and usually it's self-resolving. And then there's Hep E, which is an RNA virus, and it's kind of endemic in some parts of Asia, and it resembles hepatitis A clinically and prognostically, but just remember that it's very deadly in patients that are in the third trimester of pregnancy specifically. So you just need to watch out for that. Okay, guys, 45-year-old man presents with multiple episodes of bloody stool over the past 2 hours. Medical history includes Hep C with ascites, alcohol use disorder, and recent endoscopy showing peptic ulcers. Vital signs are BP 66/45, pulse 134, respiratory rate 24, temp 36.6, SpO2 93. Physical examination notable for non-tender, distended, firm abdomen, and melena. After starting IV fluids, what's the most appropriate pharmacotherapy? This one's a little tricky.
Octreotide and Ceph.
Okay, that's a great first thought. Just looking at this one's tricky. Like I said, that the stem says that he's got a recent endoscopy showing peptic ulcers. They don't talk about, they don't particularly say he doesn't have varices, but they're not commenting on it. So let's just assume for the sake of this question that he does not have any varices on recent endoscopy.
Okay, so pantoprazole.
Yeah, so pantoprazole and Cipro. This question certainly could be a little bit better written. But again, just remember, he's got peptic ulcer disease, and he also has cirrhosis. So yes, you can give PPI, but remember that he's got also this abdominal distension, and so he can get SBP. And for that, ceftriaxone and Cipro are really the best choices for his abdominal pain and distension. Okay, 39-year-old man comes to the physician because of anorexia, malaise, dark urine, and upper abdominal discomfort. He's febrile or almost. Physical exam shows scleral icterus and moderate right upper quadrant tenderness. The liver is palpable below the right costal margins. Laboratory studies show surface antigen positive, surface antibody negative, core IgM positive, and the E antigen positive. Which of the following was most likely change in his serological findings when this patient enters the window period?
Is it E, he will become surface antigen negative?
Correct. Yeah. So remember, guys, the definition of the window period is surface antigen and surface antibody negative, but your core antibody is going to be positive. So the surface antigen and surface antibody is negative, core antibody is positive. That's the only way you're going to be able to tell you have an active infection. Questions? Hi, Manish. It's nice to see you. All right, guys. Biliary tract disease. So this is a continuum of disease. That's kind of how I think about it, right? You have your asymptomatic gallstones. Sometimes you get an obstruction and you get biliary colic. Sometimes the obstruction leads to inflammation, infection, and you get cholecystitis, right? Sometimes you get a stone in the common bile duct, okay? And then you can get choledocholithiasis. And sometimes that stone can cause a backup and inflammation of the biliary tree. It can cause an infection in the liver and you can get cholangitis, okay? So it's all kind of a continuum. We'll start with the asymptomatic gallstones, right? So most gallstones are cholesterol or mixed stones, about 80%. Mostly, the classic risk factors are like the fat fertile female 40, the 4Fs. But you can also have patients that have diabetes. Classically, Pima Indians get kidney stones, and folks from Asia can get pigmented stones. I don't know if they're going to ask about that. Seems like a bit of an outdated thing. But if you have asymptomatic stones, you can just leave them alone. You can get a prophylactic cholecystectomy. Sometimes you can do a lithotripsy if it's a calcium containing stone, but you can also do dissolution with oral bile acid pills. You can really just kind of neglect it and leave it alone if it's asymptomatic. So yeah, so sometimes a stone can cause obstruction. right? So the bile can't pass. You're going to get increased bile pressure and then essentially impaired circulatory lymphatic function. And then you get inflammation and translocation of the gut bacteria. And because you can't get the bile to excrete from the gallbladder, it just essentially backs up and causes this inflammation and then infection. And that's that's what cholecystitis is essentially, right? So the way to differentiate just plain biliary colic versus cholecystitis is you're going to have right upper quadrant tenderness with biliary colic, but with acute cholecystitis, you may have tenderness plus low-grade fever, plus or minus jaundice. You may feel a palpable gallbladder, and you probably will have obstructive LFTs. So LFTs will be a little bit elevated. Maybe your bilies will be a touch elevated as well. Just remember that your white count is going to be normal in about 40% of the patients with acute cholecystitis. So if the patient has sonographic Murphy's, you have an ultrasound that's concerning, but they don't have they have a normal white count, that does not rule out cholecystitis. Remember, cholecystitis is kind of a broader picture of all these other factors and ultrasound findings. Just briefly, let's talk about evaluation of LFTs. So there's hepatocellular, cholestatic, and cirrhotic presentation of LFT abnormalities. And sometimes they'll just give you values and ask you kind of what's going on. And if you know which process is related to which LFT abnormalities, it might help you figure things out. So your hepatocellular patients, they're going to have increased AST, ALT. Your patients that have cholestatic disease are going to have an increased direct bilirubin and alk phos. And your cirrhotic patients are going to have increased coags because they're going to have poor synthetic function. And they're also going to have increased bilirubin and a decreased albumin. So that will hopefully help you differentiate a little bit about what's going on when there's a tough case presented. Okay. So the first line for diagnosis of cholecystitis is the right upper quadrant ultrasound. In theory, a HIDA scan is the most accurate. So sometimes they ask you what's the most accurate test as opposed to the first line. And in theory, the HIDA scan would be the most accurate. So you use a HIDA scan when the ultrasound is equivocal or when you're worried about a cystic duct stone. So if they're asking you what the first line test is, it's ultrasound. If they're asking you for the most accurate test, it's HIDA scan. The findings of cholecystitis on a ultrasound are thickened wall greater than 3 millimeters, stone present in the gallbladder, pericholecystic fluid, sonographic Murphy's, sludge in the bladder, in the gallbladder, or wall edema. Okay. And the treatment is IV fluids, NPO, surgical consultation, antibiotics, so Zosyn or something like that. And then they get a cholecystectomy. There's some complications. You can get perforation, you can get gallbladder empyema, you can get a gallstone ileus. Acalculous cholecystitis is about 5 to 10% of cases. It's usually more common in critically ill patients. And it happens because there's bile stasis. And you really need to work on surgical intervention or percutaneous drainage in these patients. There's a higher rate of mortality with these folks. So cholangitis, again, you have choledocholithiasis and then things get backed up and you get inflammation, gut bacterial translocation and inflammation. Typically this is gram-negative bacteria, and you can very easily get septic, and death is 100% if you're untreated. So it's really important to remember kind of how this works out. So just remember Charcot's triad and Raynaud's pentad. So Charcot's triad is right upper quadrant pain, fever, jaundice. And then the pentad is mental status changes and shock as well. Okay. And then if you don't have cholangitis and you just have choledocholithiasis, you just have a stone lodged in the CBD, it's appropriate to have some ductal dilatation on ultrasound, but just remember that abnormal is age in decades times the millimeter. So if someone is, 70 years old, it's okay for them to have 7 millimeter ductal dilatation in the CVD, and kind of calculate like that what's normal. But for these patients, you're probably going to need an MRCP because you're not going to see anything on the ultrasound. But you know, they're going to have some sort of LFT abnormalities and some bilirubin abnormalities. And you know, you're going to need to kind of know what's going on. So you're going to get an MRCP on these patients. Okay. Cirrhosis. So cirrhosis is patients essentially get portal hypertension, and that leads to ascites. They can have SBP, they can have encephalopathy, they can have variceal bleeding, as we kind of touched on. We're going to talk a little bit about that now. So 45-year-old man with alcoholic cirrhosis with confusion, increased abdominal pressure over the past week, denies fevers, chills, nausea, vomiting, and diarrhea. Physical examination reveals mild diffuse abdominal tenderness. You get a paracentesis and there's 520 white blood cells with 90% PMNs. Protein is high and glucose is normal. What's the best course of treatment?
Third-gen cephalosporin.
Yes. So this patient has SBP. So bacterial infection of the ascites without apparent source. And so the most common bacteria really are E. coli, Streptococcus, and Enterococcus. And patients may have fever, they may have abdominal pain, sometimes they're in shock or they have encephalopathy, but about 30% of these patients are asymptomatic. So if you have a patient that has a history of cirrhosis and they have an elevated bilirubin, or they have a white count, or they have really any abdominal tenderness or whatsoever, or even if it's mild and they're not complaining about it, very high suspicion for SBP and giving them ceftriaxone or Cipro. Those are the two medications that are most commonly given, the third generation cephalosporin or Cipro, and you need to admit these patients. If you do a paracentesis and they have more than 500 white blood cells or 250 poly PMNs, that's indicative of SBP, and you need to give them antibiotics. So some patients might have hepatic encephalopathy. They're going to be shaky, they're going to be confused. Precipitants include dehydration or infection, GI bleed, or medication noncompliance. And their ammonia is not always going to be elevated, but if the picture looks like it's encephalopathy, like they're a little confused, you can give them some lactulose or rifaximin, or you can treat their underlying condition. Okay, I think that's it for the first half. Do you guys have questions?
No.
No.
Okay. Do you guys want to
Alex,
take? Yep.
that was great, man. The charts and the slides were really wonderful. Sorry I couldn't speak earlier. I just was like mid texting email. Just to the group here, and I think you mentioned this, but just to highlight, we underappreciate when people have SBP.
Yes.
So you should be very liberal with tapping. I think that's just one for like diagnostic tapping, and often that's one that we,
Yeah.
it ends up being positive. Of course, you could introduce an infection, if it's not done right. But overall, it's one of those things that it's been surprising over my career how many times people are positive with minimal symptoms, as you highlighted with the 30%.
Yeah.
That's
Yeah, it's a while ago we started a project at Cornell. I think when I was a resident, about it was like early tapping, because I guess there was such high mortality rate for these patients at Cornell. And so I think the indication really is if they have even slightly abnormal LFTs or billies, certainly if they have a white count, anything odd, the expectation was that we would tap them before we would admit them to the medicine service, and cover them empirically for antibiotics. So yeah, for you guys clinically, less so for the test. Certainly you should have a consideration of this on your diagnosis for anybody that's cirrhotic or has a history of ascites for other reasons. Do you guys want to take like a 3-minute break, 5-minute break, come back at 9:30?
Yeah,
Sure.
5 minutes sounds good.
That works.
Okay, great. We'll come back in 5 minutes and we'll do the second part. That guy's
I'm here.
back
Back, we're back.
around 2.
Mhm.
Let me share my screen. Okay, part 2. This is going to be about pancreatitis, bowel obstructions, and then diarrhea. It's going to be fun. Okay, so we'll start with pancreatitis. So pancreatitis is the pathophysiology of it is essentially inflammation and enzyme release, which leads to autodigestion. There's no capsule to the pancreas, so you can get some necrosis and then bleeding. And then ultimately you can get some walled off granulation, and that's what a pseudocyst is. So sometimes you get a CAT scan with a pseudocyst finding. Essentially, it's just walled off granulation and chronic inflammation. Symptoms are mid-epigastric pain that goes to the back. Sometimes patients have anorexia, nausea, vomiting, have low-grade temperature. And they're going to be tacky. They can have hypoactive bowel sounds. They're going to have epigastric tenderness. Usually these people don't have rebound. These are kind of pathognomonic findings on examination, and sometimes you'll have question stems with these signs and it will point to the answer. So over here you have colon sign, which is periumbilical ecchymosis. And over here you have Gray Turner sign, which is flank ecchymosis. And this is ecchymosis from hemorrhagic pancreatitis. I don't think I've actually ever seen this in the real world in 10 years of doing this, but it's on the test almost every time from what I remember. The causes of pancreatitis have an interesting mnemonic, bad shit, that's how I remember it, but really the most common are biliary causes and alcohol. They account for about 90% of all pancreatitis cases. But certainly you can get scorpion stings, which we all love to remember, hypertriglyceridemia. You can get idiopathic disease. Post ERCP also happens with some frequency. And then you can get it from NSAIDs or sulfa drugs or steroids. You're going to get a lipase on these patients more than amylase. And these patients usually will have an elevated white blood count. They may have, if they have a hemorrhagic pancreatitis, decreased H&H. They're going to have a elevated BUN creatinine because they're not going to be able to eat very well. They're going to have so much abdominal pain. They're going to be dehydrated. And they may have elevated glucose. And classically, they're going to have hypocalcemia. And that's because you're going to get calcium deposits in the retroperitoneum. And on X-ray, sometimes you can actually see these calcium deposits. So these kind of white flecks, that's calcium deposits from chronic pancreatitis. And those patients may be hypocalcemic. You can also get an ileus. And so, you may get an X-ray that looks kind of like this, where it looks like an ileus. Just remember that you're really going to get a CT for the complications and to rule out other causes of pain. You can get an ultrasound to rule out and evaluate for other biliary etiology. An X-ray of the abdomen or a chest X-ray really are not that valuable in these patients, right? And you're going to do NPO for these patients. You can give IV fluids, analgesia. You may consider antibiotics. Just remember that the management for these patients has changed a lot. We used to admit all of these folks. Now we see if they can tolerate PO slowly and manage their pain and go home. But even 5 years ago, we were admitting all these patients, so they were always NPO. So the test lags. So sometimes you may get, a question about the patients on NPO for their pancreatitis. Lots and lots of complications. Pancreatitis we see fairly frequently, and I think it's underappreciated how severe of a disease it is. So you can get pleural effusions, you can get ARDS, you can get ascites, you can even go into DIC. You can develop an abscess and get sepsis. I would just remember the Ranson's criteria, kind of like the hepatitis C graphs right before your test. So, you know, there's a Ranson's criteria at initial presentation and a Ranson's criteria at 48 hours. And depending on your score, there's certainly high mortality. So patients with a score of, 5 to 6 are at 40% mortality. That's really high. So you need to calculate this. But again, just remember these numbers. And there's a bit of a pattern you can kind of follow. I think I only had this asked one time across the 4 years of residency, but I think it was on my boards. Okay, so next is bowel obstruction. Just remember that you can distinguish between the two, large bowel or small bowel, based on mucosal markings. So a normal small bowel measures less than 3 centimeters, and it usually is like plicae circularis. So almost these kind of like round discs, right? Like you see here. They're circular, they have villi, and they increase the surface area for absorption. Large bowel usually measures less than 5 centimeters, and they're more like hostra, so they kind of make the colon look segmented. They don't go all the way through. So the plicae circularis look almost kind of like discs, and these kind of look like more divots. And they kind of make the colon more segmented. The symptoms of bowel obstruction, you can get belching or burping, you can get diffuse intermittent abdominal pain, or sometimes the pain can be constant. You can sometimes get vomiting, and other times you get constipation and you don't have any flatus. Just remember, someone with a bowel obstruction could come and you can ask them, have you had a bowel movement? And they could say yes, but that's just actually them emptying their bulb distal to the transition point and the point of obstruction. So just because someone had a bowel movement doesn't mean that they don't have an obstruction. I think that's something that we kind of laser focus on. But again, it just doesn't, discount the chance of obstruction totally. They're going to have hypoactive bowel sounds. They're going to first be hyperactive and then become hypoactive. They're going to feel distended and diffusely tender, and they may feel tympanitic. Small bowel obstructions are caused by adhesions primarily, but can also be hernias. Large bowel obstructions are almost always tumors, but it can also be from volvulus or impaction or diverticulitis. So this is a small bowel obstruction. You could see that the small bowel is dilated more than 3 centimeters. You can kind of make out the plicae circularis here, although it's not perfect. And you can see that the distal bowel is devoid of air and there's nothing kind of in the rectum. This is what a CAT scan looks like with a small bowel obstruction. So you're going to see these large dilated loops, kind of. See here. Then there's these air fluid levels and these other loops, right? Where you can kind of see a straight line across the fluid levels in the loops of bowel. And then distally, if you were to follow this CT kind of further down, you wouldn't see any air. And you would look for like a transition point. Obviously, it's a static image, so it's hard to say. But a bowel obstruction, you may have increased white count. A lot of times these patients are vomiting, so they remember they're going to have a hypokalemic, hypochloremic metabolic alkalosis. And they may have a lactic acidosis as well. Okay. You're going to get a CT for these patients. You're going to NPO them. Some of them are going to get NG tubes. Sorry about that. It's been a long day. And you're going to get a surgical consult after you give them analgesia and antiemetics and antibiotics if they're really toxic appearing. So this is an ileus, right? So you can see some fluid and gas in the small bowel. You can see some air fluid levels, but down here you can still see there's some air in the rectum. And so you know that this is more in line with an ileus. And an ileus can happen for a lot of different reasons. It can happen for electrolyte and metabolic dysfunction. It can happen from trauma or infection, or a toxidrome. And it's usually just a functional kind of blockage or a partial blockage, and it's not so much mechanical. If you treat the underlying cause, for example, like patients post anesthesia can also often get ileus. Sometimes you need to just give them medication to start moving their bowel and give them a good bowel regimen, and then they'll kind of poop. And so that's not a mechanical obstruction, it's just a functional obstruction, right? This is a sigmoid volvulus. So I'm going to go back to the picture in a second, but a sigmoid volvulus is a single dilated loop. It arises out of the left pelvis, and it looks like a bent inner tube. If you look online, there's variability in what's, how they describe this. Sometimes they describe this as a coffee bean. Sometimes people describe cecal volvulus as a coffee bean. I think about this as like a bent inner tube, and it looks kind of like this. And I think about sigmoid, they're two old people, and they get sigmoid volvulus in the left pelvis. And this is more of a cecal volvulus, which is in younger patients. And it's single dilated loop in the left upper quadrant. And it's usually in younger patients, classically marathon runners. So again, I can just show you guys the picture difference. So this is what a cecal volvulus looks like in the left upper quadrant. And this is what a sigmoid volvulus looks like arising from the left lower pelvis, but certainly looks a little bit different. So again, sigmoid volvulus is for patients with chronic severe constipation. It's in elderly and psych patients, and cecal volvulus is usually in younger patients and classically because of incomplete fixation to the posterior abdominal wall of the cecum. Okay, and the treatment is really the same as this SBO, but for a sigmoid volvulus, you can also get a sigmoidoscopy with a barium enema, which can be diagnostic and therapeutic. And for cecal volvulus, you really need early surgical intervention to reduce it and kind of pin the cecum to the posterior abdominal wall. Otherwise, it's going to get recurred. It's going to recur. So which of the following findings is least supportive of the diagnosis of acute pancreatitis? Anybody have an answer?
Is it it's either left pleural effusion or one of the electrolyte abnormalities, but I think it's left
The
pleural.
least supportive.
How about hypercalcemia?
Yep, that's right. Because these patients are going to have hypocalcemia, right? Because they're going to get the calcium deposits. So the least supportive finding is hypercalcemia. What is the most common cause of a condition depicted on X-ray? What do you guys think this is?
Adhesions, are there air fluid levels?
Correct. So this is an SBO. Which of the following regarding the most likely which of the following regarding the most likely underlying process is correct? So what do you guys think this is, first of all?
It looks more like sigmoid.
Correct. Yep. So risk factors include inactivity and chronic constipation, right? In those sigmoid patients.
Yeah.
Elderly folks. 52-year-old man presents with severe abdominal pain, nausea, and vomiting. His last bowel movement was 3 days earlier. Physical examination reveals a diffusely tender abdomen without rebound or guarding. During the examination, he mentions that he got stabbed in the abdomen a few years earlier and had to get scoped. Placement of an NG tube yields copious bilious material. Based on the presumed diagnosis, which of the following abdominal findings is most likely? Abdominal X-ray findings.
dilated bowel with prominent plicae.
Correct. Yeah, because he's going to have an SBO. You know, he's got bilious vomiting, so it's it's proximal to the pylorus. That's where the obstruction is. Great. Okay. Moving on to mesenteric ischemia. So these patients are going to be sick. Sometimes it can be sudden, and then you're thinking more kind of like an arterial occlusion. Sometimes it can be insidious, and it can be more like a venous or a non-occlusive mesenteric ischemia. Classically, patients may get diarrhea with blood. They may get fever, and they may get kind of these like anginal abdominal pain symptoms. Risk factors include patients with AFib, patients with clotting disorders, so hypercoagulability or thrombosis history. And then sometimes you can get that non-occlusive, low-flow, insidious mesenteric ischemia in patients with CHF and hypotension that just don't have enough cardiac output to feed the mesentery. And most of the time, these patients are going to be elderly. But AFib with a patient with sudden pain out of proportion on exam should really make you think that maybe they threw a clot and have mesenteric ischemia. So again, you're going to have this pain out of proportion on exam. Acute mesenteric artery ischemia accounts for about 65 to 75% of the cases. And mesenteric venous thrombosis is the more common, is the next common one. And then you get non-occlusive from reduced cardiac output. Just remember that the mesenteric ischemia, for mesenteric ischemia, there's a lot of collaterals for the mesentery. But sometimes you can, you know, minimize blood flow to a part of the mesentery, and that can cause some of the discomfort and necrosis that leads to mesenteric ischemia. So you're going to have a white blood count that's elevated. You're going to have low bicarb, and remember that lactate can be a late finding. And the angio is the gold standard. So a CT angio is the absolute gold standard on these patients. On regular CT, you're just going to see bowel wall thickening, but on angio, you're actually going to see the lack of extravasation and the actual infarct. So these patients are really sick. So remember, you're going to do IVO2 monitor, you're going to NG tube them most likely. You're going to do broad spectrum antibiotics, and you're going to call surgery. You might need to heparinize them, but there's a very, very high mortality for these patients. I don't think anybody's going to ask you about this piperavine through angiographic catheter. I think that's a kind of a historical thing that people did, but not anymore. Questions about mesenteric ischemia?
No.
Okay. Moving on to Crohn's versus ulcerative colitis. Okay. So there's going to be a few questions about this, I'm sure, on your in-service. So just keep an eye on this one. So you're going to have Crohn's patients are going to have this like low-grade fever, flatulence, diarrhea, recurrent cramping, abdominal pain, and they may have tenderness that localizes to the right lower quadrant. The presentation, because of that, could be kind of a pseudoappendicitis. Oftentimes they're going to get perianal complications, and then they're also going to have these extra intestinal manifestations like dermatologic or ophthalmologic. Just the difference, and it's always kind of hard to remember, but Crohn's disease is transmural and has skip lesions and cobblestoning. And ulcerative colitis is going to be continuous and uniform. So Crohn's is skip lesions and cobblestoning. Ulcerative colitis is continuous and uniform. Ulcerative colitis is transmural, so the entirety of the mucosa, entirety of the GI tract. And ulcerative colitis is limited to the mucosa and the submucosa. The rectum is usually involved in ulcerative colitis. Go back a little bit. The treatment for both these is going to be fairly similar. You're going to, if they have a Crohn's flare or an ulcerative colitis flare, you're going to give them fluids. You're going to make sure they're hydrated. They don't have metabolic derangements. Make sure their pain is not out of proportion. Make sure they don't have any acute kind of complications such as a fistula forming or an abscess. And they usually get admitted. Sometimes Crohn's patients can get perineal abscesses or fissures. They can get obstructions or abscesses, and they can also get toxic megacolon. And some of the same things can happen in ulcerative colitis as well, but they can also get hemorrhage, and they have much more higher frequency of malignancy as a complication. So that's the other thing worth remembering. So looking at these side by side, Crohn's is the entire GI tract except the terminal ileum. Ulcerative colitis is most often in the rectum. Crohn's is skip lesions, while ulcerative colitis is contiguous. Crohn's is transmural, so full thickness, versus ulcerative colitis, which is usually involved in the submucosa and mucosa. Crohn's has kind of crampy pain, and characteristic for ulcerative colitis is bloody diarrhea. And malignancy is much more common with ulcerative colitis than it is with Crohn's. Questions about that? Okay. We're going to talk a little bit about diverticulitis. So patients with left lower quadrant pain and fever. Classically, the teaching is right-sided diverticulitis can happen in Asian populations. I feel like they asked one time about that. But you're going to have left lower quadrant tenderness. You're usually not going to have any bleeding. And patients will have like a low fiber diet. A diverticula will get some impaction with fecal material. There'll be some inflammation. You get an infection. Sometimes you get a little perforation. And you're really going to get a CAT scan on these patients. And if it's just like a simple diverticulitis, you don't need to consult surgery. You can just give antibiotics. Augmentin is the choice, but ciproflagyl, levoflagyl was what we were giving before up until a few years ago. You're really only going to need to get surgery involved if they have an abscess or some other kind of perforation or other complication of the diverticulitis. You can also get something called an angiodysplasia. This is a patient's going to show up with painless bright blood per rectum. Their exam is often normal, and it's just an acquired defect, which usually self-resolves, but sometimes requires colonoscopy and then maybe even a subtotal colectomy to be curative. But these patients are going to present with copious amounts of bright red blood per rectum, and it's usually going to be painless, so no pain. Switching gears a little bit, this is a little bit of a mixed bag. This section, we're going to talk a little about Hirschsprung. So congenital abscess of the myenteric parasympathetic ganglia in the distal colon. 20% of neonatal obstructions are because of Hirschsprung, and usually it presents as a failure to pass stool or meconium in the newborn period. And you're going to have a palpable colonic stool without the presence of stool in the rectum on exam. A barium enema may give you an idea of what the diagnosis is, but a rectal biopsy looking for that myenteric parasympathetic ganglia is really the definitive diagnosis. And you really need to admit these patients to get surgery involved and to get a partial colectomy in these patients early. Meckel's diverticulum. These are some key words for you guys. So these are patients that are going to have some occasional cramping abdominal pain, and they're going to have persistent painless brick red hematochezia. And this is a remnant of the omphalomesenteric tract. So it's ectopic tissue from the stomach or the pancreas. And this is the one that's like the rule of twos. So it's 2 centimeters long, 2 centimeters wide, within 2 feet of the ileocecal valve. 2% of the population, and 50% are symptomatic by age 2. So this is what it kind of looks like, a Meckel's diverticulum in the small intestine. And you can get a Meckel scan, which is a technetium 99 scan, which you get take up by ectopic gastric mucosa, and you need surgical consultation. Let's do some questions, okay? 68-year-old male, brought in by EMS for hematemesis melena. He's got a history of aortic graft. Those are his vital signs. What's the next appropriate step?
I'm gonna go with CT.
Yeah. Or he just needs to go
Okay.
to the OR.
Yeah.
I would
That's
say
good.
ultrasound. I think you can diagnose AAA and
Yeah. This guy is hypotense, guys. So just,
Yeah, that's right.
just
Yeah, maybe just the OR then.
yeah. So the answer is laparotomy, because he's got an aorta enteric fistula. So anybody with an aortic graft that comes in with melena and abnormal vital signs just needs to go to the OR, because it's an aorta enteric fistula until otherwise proven. Denise, you're right. Probably if he came to the Cornell or Columbia AD, you may ultrasound him to make sure there's, look for blood in the belly and things like that. But you're not going to be able to send them for an official ultrasound because they're unstable. So if someone's got unstable vital signs, think about how that changes your disposition on the test. Okay. So you can't take these patients out of the ED for an EGD or an ultrasound or an X-ray or a CAT scan. They need a definitive destination because they're hypertensive. Which of the following is least likely to be a contributing factor in the developing of mesenteric ischemia?
AFib.
So it's least likely. Remember, patients with AFib are going to, high risk of mesenteric ischemia.
In between like 1 and 5, I just have to think about it a little more.
If on Willebrands, they're really bleedy.
Yeah, they're really bleedy, exactly. So they're not going to clot, they're going to bleed. So it's less likely in a von Willebrand patient. Antithrombin 3 deficiency, I think they're more predisposed to clotting. So the answer here is 5, von Willebrand, because they're going to bleed instead of clot. In patients with ulcerative colitis, which of the following is correct?
Rectal involvement. All right.
I think rectal involvement is more common in ulcerative colitis.
I think this is transmural, so maybe the 3.
Crohn's is transmural.
Thank you.
This one's tough. The answer is 5. There's toxic megacolon is more common in Crohn's. So ulcerative colitis is not transmural. Crohn's is transmural, like you guys said. It doesn't usually affect any part of the GI tract. It usually affects the rectum in almost all cases. Not 50%, but probably more than that. And extraintestinal symptoms are quite common. So the only answer that fits is toxic megacolon. Which of the following symptoms is least likely to occur with diverticulitis? Anybody? So remember, diverticulitis does not have bleeding, right?
Oh yeah.
So you really shouldn't have bleeding in diverticulitis. Okay, final stretch here. We're going to talk about everyone's favorite thing, diarrhea. You guys excited?
So excited.
Very.
Okay, good. Okay, so most diarrheal illnesses are viral, right? So rotavirus, low-grade fever in kids, nausea, vomiting, watery diarrhea. You can get Norwalk, which is from contaminated food and water in adults. Bacterial diarrhea is a little bit less common, but still accounts for about 1 in 5 cases. It's more invasive and involves the large bowel. And a lot of times, bacterial diarrhea can be bloody and mucousy, and sometimes you can get fever. And that's when it's more invasive. And then sometimes bacterial illness can be toxin mediated, and then it's usually more watery. Sometimes the question asks you if the, if there's fecal leukocytes. So invasive bacterial diarrhea has fecal leukocytes, but usually toxin mediated bacterial diarrhea does not, except for C. diff. So the way to remember invasive diarrheal illnesses is this messy Cassie that you guys have probably heard about before. So it's Vibrio and Vibrio, which is the one that doesn't fit, but then it's enteroinvasive E. coli, Salmonella, Shigella, Yersinia, Campylobacter, C. diff, and ETEC, or EHEC, sorry, enterohemorrhagic E. coli. So for diarrheal illness, you're going to give them loperamide for symptomatic relief. It shouldn't be given for more than 2 days, and it should not be given in patients that have fever or bloody stools. Sometimes you can get bismuth, which is like anti-secretory, and sometimes you can give antibiotics for traveler's diarrhea or Shigella or Campylobacter. Just remember, it prolongs the shedding for patients if they have Salmonella or C. diff, and increases the complication rate for patients with O157H7. So, if the story is very classic for traveler's diarrhea, sometimes you can give antibiotics, typically a gram of azithro, and usually patients get better. Campylobacter and Shigella can also benefit from antibiotics. You just have to make sure it's not something like Salmonella or C. diff. There's also parasitic diarrheal illness. You can check the stool for ova and parasite, and the treatment really is pathogen dependent. A couple of special populations that they love to test for you guys to remember. So if you get a recent immigrant or traveler and they have bloody diarrhea, you're going to think about Entamoeba histolytica. And typically it's patients in the question stem from Africa, Asia, or Latin America. If you had an ingestion of shellfish, you're going to think about Vibrio. If you had persistent abdominal pain, mesenteric adenitis, erythema nodosum, or any other weird immunologic manifestation, you're going to think about Yersinia. If you have a hospital patient with recent exposure to antibiotics, you can think about C. diff. And if you have untreated water exposure and illness that presents for more than 7 days, you're going to think about Giardia or Cryptosporidium. Persistent diarrhea for a long time in a normal or an immunocompromised patient, you're going to think about Cyclospora or Isospora. And if it's someone with advanced HIV disease, you can think about CMV, Cryptosporidium, Microsporidium, or Cyclospora, Isospora as well. Okay, this one is worth thinking about for the test and for real life. So this is a Shiga toxin producing E. coli, and it's usually caused by a small amount of feces on undercooked beef, fruits, vegetables, raw milk, and patients usually have severe abdominal pain. You can get a culture for this, but you don't want to give antibiotics for these patients because it increases the risk of hemolytic uremic syndrome. And it's fairly common in the elderly. Up to 40% of patients that have this infection may develop HUS. So if you give antibiotics, you may be increasing the risk of that. So again, sometimes it does make sense to get a GI PCR. They love the questions around Cingulata or Cingulata and scromboid. So Cingulata is this heat-stable neurotoxin which affects your sodium channels. And classically, you're going to have this hot and cold reversal after eating it. And patients are going to have these neurologic symptoms. And it's classically after eating grouper or snapper. So hot cold reversal is Cingulata. Scromboid is going to be histamine toxicity and this peppery metallic taste classically. And usually the question stem will have something about tuna or mahi-mahi. So again, this one is really just about learning keywords. Hot cold reversal for Cingulata, peppery metallic taste with histamine toxicity for scromboid. Let's do a quick diarrheal review. I'm gonna read out the first sentence and you're gonna tell me what you think what you think bacteria is involved. So mucoid bloody and high fever and febrile seizure in an infant. Anybody ideas? This one's a little tough.
Seizures. Oh shit, Shigella.
Shigella, yeah. What about a pet turtle or iguana?
Oh, Salmonella, because I had to give my turtle back when I was a kid.
Yep. What about a patient without a spleen or a patient has sickle cell? Remember, there's a few that you're really worried about, but in terms of diarrheal illness, salmonella. What about pseudoappendicitis? We talked about it a little bit. Yersinia. And again, I would just remember this before the test. Just look this over the day before the test and try to remember these keywords. Fecal white blood cells after poultry or eggs is from Salmonella or Campylobacter. If you don't have fecal white blood cells after poultry or meat, it's more Clostridium perfringens. So remember the difference with fecal white blood cells. Profuse watery diarrhea after antibiotics is C. diff. What about after potato salad or mayo?
Staph.
Perfect. What about after fried rice?
Campylobacter.
Okay. One more.
It's the sketchy video where they have the Viking ships, and I can't remember.
I can remember the sketch, but I can't remember that.
It's one of the toxin. Oh, bacillus. Yeah.
Be serious. Be serious. You ate some fried rice.
I'm serious.
Sorry.
What about after raw oysters?
Vibrio. Wait.
Yep, Vibrio. Yep. What about after drinking from the mountain stream? Sorry.
Giardia.
Yeah, remember this is gonna be watery diarrhea for 7 days, usually the story. AIDS patients. Remember they're gonna get isospora and cryptosporidium. They can get that as well. Hemolytic uremic syndrome or TTP.
EHEC.
Good job. Diarrhea followed by GBS.
Oh, this is the Campylobacter one, right?
Correct. Yep. Travel to a foreign country. Traveler diarrhea.
ETEC.
Okay. Anorectal disorders. Almost done. So you can get a pineal cyst. This is an infected hair follicle at the top of the natal cleft. You can get an abscess. It most happens in males. and you just need a surgery cyst incision. If you try to cut this and don't get the entirety of the capsule, it's just going to come back. You can get perirectal abscesses, and they can show up in a lot of different places. Just remember that you're really worried about cutting these because you don't want to make a mistake and cut the sphincter. So perianal, perirectal abscesses are going to have rectal pain that's worse with defecation. Ischiorectal are going to have this throbbing gluteal pain. Intersphincteric will have more dull pain and rectal fullness. And again, it's just obstruction of the glands at the base of the anal crypts. You can do a rectal exam, you can do CT imaging, but again, maybe surgery should really be doing these because you want to watch out for the sphincter. You can also get an anorectal fistula. It's usually from it's an abnormal tract between the anal canal and the skin, and it's a common complication of perianal or ischiorectal abscesses. And just remember that it's associated with irritable bowel disease, cancer, and radiation therapy as well, and you need surgery. So that's a fistula. A fissure is just some rectal bleeding. You can get some pruritus, and it can happen after a diarrheal illness. It's uncomplicated if it occurs in the midline, but if it's not midline, then you should consider other etiology, like maybe it's related to underlying Crohn's or something like that, or ulcerative colitis, actually, sorry. And you just really need to do stool softeners and laxatives and sitz baths. Hemorrhoids, so internal versus external is really what you're going to need to understand. So internal hemorrhoids are painless, but you're going to have some bleeding. External hemorrhoids are really painful and they can get thrombosed. Externally, you're going to feel tender mass. Internally, you may not feel anything. It just may feel really tender. Okay. So again, the treatment really for external hemorrhoids is fiber, analgesia, and sitz baths. And for internal, you're going to do soft stool softener, sitz baths. And if you're bleeding a lot or you're worried about incarceration or strangulation, then you're going to need surgery. Okay, final stretch here. So we're going to talk about a few questions. This will hopefully help us hone in on some of those diarrheal diseases. So 42-year-old woman presents with weakness of her lower extremity that started in her toes and moved up to her thighs. She says she also has had bloody diarrhea for 4 days. Her vital signs are normal. Examination reveals bilateral motor weakness and unsteady gait and diminished patellar reflexes. Which infectious agent is most likely associated with this diagnosis?
A.
Correct. This is kind of that Miller-Fisher variant of GBS. 35-year-old male presents with abdominal cramps, nausea, and watery stool after eating leftover turkey that had been sitting on the kitchen counter. Which of the following is most likely etiology?
5. Maybe not.
So staph is like potatoes,
Okay.
potato salad.
C perfringens.
Yes, turkey. C perfringens. 32-year-old vacationing in Florida with nausea, vomiting, paresthesias, and hot and cold reversal after eating seafood.
2.
Yes. Which of the following statements regarding anal fissures is correct?
It's seen after diarrhea.
Correct. 42-year-old with cramping abdominal pain and watery diarrhea. She had same symptoms 10 days ago and was prescribed amoxicillin with relief. She wants another prescription for amox. What is the best course of action? Send stool studies and
Flagell.
Correct. Flagell. Very good. And that is it. Do you guys have questions?
No, thank you so much.
Yeah, thank you.
Okay. Very good.